Okay, so I will share my screen here. Just, all right. Okay, I hope everyone can hear this, but if not, please let me know. Um, and as I said, thank you. Welcome. I appreciate everyone being here. My name is Emily Grassi. I'm the Marcus Alert Coordinator for DBHDS. And we're here for our biannual stakeholder meeting. So here's part of our agenda. We have some state updates, data reporting, training updates, legislation updates. We're also going to hear from 98E as well as our community testimonies, and then just regional updates as well. So just a little bit more detail on some of our state updates. We're going to talk about how program implementation is going. We have some financial and quarterly updates, some good information about local plan guidance and approval. Of course, we're going to share some of our data and how it's looking, training updates, and then we have some relative legislation and policy updates. So, as we mentioned during our last meeting, we have a big implementation group this fiscal year. We have about 10 to 12 sites implementing. Some of them are listed here. We are going to be really excited to report next. And I know some of the regional coordinators are going to go into detail, but at our next stakeholder meeting, we'll be able to look at co-response with the addition of these 10 sites kind of throughout the whole state, and have some really good numbers about how many teams we have, what are some of their different compositions and modalities. There's a lot of creativity happening with these 10 sites and the development of their various teams. So it's exciting to see them work through this process and to see what they're coming up with, and just how everything has been going across all of Virginia as a whole. And then looking into financial and local plan updates. So we have started, just as a reminder, some quarterly financial reporting. They follow the same schedule as the data reporting. So whenever community services boards or sites have to submit their data each quarter, they will also have to start submitting quarterly finance reports. So here's just some reminders for due dates for quarter 3, being April 15th and August 15th. For quarter 4. It's a different email than you will submit for the data. It can go directly to my email address or the community service board that have all of the already implemented, and then the oncoming sites, they have their own Teams channel. They can also put it in there, whatever works easiest for them. In addition to that, we are trying to get ahead of the fiscal year. So we are asking sites to pre-submit their plan or their budget for the upcoming fiscal year. Our anticipated date for this being due would be April 1st. I realize I did not put that on there. I'll make sure I update that before I send out the PowerPoint for everyone. We want to make sure, because we're hopeful as I go into the legislation and other updates, we're hopeful that some of the asks to remove that blanketed 600,000 funding for each site can be moved towards a needs-based funding. So we want to make sure that we're kind of being mindful of that and getting ahead, and then just making sure that each of the sites are getting the support and the needs, their needs met as well. So The other thing is that we have officially updated the new local plan guide. It's not available on the website just yet because we are having to ensure that particular like guidances and resources on the DBHDS website as a whole has been updated. It has been shared. I think it was back in sometime in the fall. I can't remember the exact date. September, October, so with all of the regional coordinators. So if you're a locality that will likely be implementing in fiscal year 27 and you want to get a copy of that, please reach out to your regional coordinator and they can give that to you. We should have it up on the website for everyone sometime around April. I think that's the due date for us to have everything updated. So there wasn't a significant amount changed other than where implementation has been and where we see it going. We tried to make each of the outline and the required documents for submitting your plan a little bit more detailed and that you had more structure and you could clearly figure out, okay, what was needed when I submit my local plan versus it being ambiguous. In addition to that, we are about halfway through reviewing all of the previous local plans to see if there's any that can be removed from conditional approval and have full approval. Of course, we're also reviewing the 10 Community Services Board who are in their planning year. And so we're about halfway through. We're hoping to have full statewide full approval by July 1st of 2026. Of course, some of the barrier statements with developing their local plan is that partnership and getting some of the documents that are required from the other stakeholders within your locality. So we recognize that everyone's working and they're doing their best. So we're trying to ensure some grace and some flexibility, but that's where we're looking to move forward. And kind of going over the data so far. So again, I realize I mixed these two up and oops, wrong way. I shared the financial reports and I meant to put data reports, but Q3 and Q4, again, do same with your financial reporting, April 15th and August 15th. This is for both PSAP and co-response. Here is that email. If you guys don't have it, it is on the template as well, but if anyone needs it again. So the co-response data template is new, right? It started I guess this current fiscal year. And I know that lots of stakeholder feedback has asked that there be a revision of that template and refining some of the KPIs that were originally put in there. So again, I'll go into more detail on that when we get into the legislation updates and so on and so forth. But we do know that ask has been made just for, consistencies and really to get a good understanding about, well, what are the KPIs collecting currently? How is it working? How is it functioning? We're leaving it as is for the time being, but we do know that that is something that needs to be updated, and we appreciate that feedback. In addition, when we go through some of this data, we just want to look at that there still seems to be some lower transfer rates from level 1 calls to 988 than we had expected. So we are in the process of looking at these trends to better understand workflow and operational or even training factors. So that way we can try to help support these two systems. So yeah, and then ongoing focus, we're still looking at, data quality and consistency. Some of the data isn't always turned in fully complete, which again, we'll show on the upcoming slides. We also want to make sure that alignment between, what's being reported and what we're seeing matches. and just kind of continuous improvement and evaluation of statewide infrastructure to figure out if there are different ways that we can make this picture more well-known or robust. So looking at quarter 1, as I shared, some of it was just left blank. So that kind of skews our data. But it does seem like our PSAPs are getting a lot of level 1s and level 3 calls. Good amount of variety between the dispatch on those calls. And then this is also similar for quarter 2. And so we're really trying to see what is the trend with transferring calls, but then also what are the different options that can be dispatched for each of these alert levels. Again, just looking at the co-response data, seeing how many of each of the CSBs, how many incidences they responded to, and which of the Marcus alert levels they responded to. So it looks like they're right where we would want it to be, responding to a lot of level 3 calls. That's typically identified in their local plan guides, but then also level 2. So I think these numbers look really great. And as I mentioned, I know that there's a lot to be noted or to be changed or reviewed for the KPIs, which I will get into momentarily. Denise had a conflict of interest, so she couldn't be here, but I did ask her to share with me some information for mobile crisis for everyone. So it looks like they're at about 79% of their goal. So they have 110 teams funded. I know the goal is 140. But that's still really good numbers, and it shows that there's a lot of progress in expanding community-based services and strengthening some of the other alternatives to law enforcement. She shared that the average time it takes to complete dispatches seems to be about 40. I'm sorry, they have completed about 41,000 completed dispatch. The assessment time is about 51 minutes. And the response time as a whole is 48 minutes. So it seems to be really within that level, right, where we're wanting it to be. Response time in an hour, calls are being assessed or on treatments being assessed in a good amount of time. And showing the clinical nature of the calls and the care and thoughtfulness that goes into each of the responses. She also wanted me to note that she's in the RFP process for mobile crisis training, online and on demand. It looks like it's expected to go live October 1st, 2026. I don't have any significant details on that. This was just something she shared. So if you guys have any more questions on that part of her PowerPoint, just feel free to reach out to her. But looking at our Marcus Alert training updates for both of them, I know we've been working a lot, and there's been quite a few back and forth about the advanced Marcus Alert training or just the Marcus Alert training in general. We've gotten a lot of feedback from different stakeholders to strengthen that, especially with it being cross-professional collaboration. So thankfully, our wonderful partnership with VCU has helped tremendously in trying to make these changes. We're now moving towards having a blended model of a few e-learning modules to be completed before the in-person training, with the in-person training being focused specifically on skill building, scenario practice, and professional development across. Our intended audience still remains the same: clinicians, law enforcement, fire EMS, peer support, mobile crisis response and 911, both of those being as available. So we want this to be anyone who's doing the groundwork and related to Marcus Alert to have a better understanding and collaboration. Again, we don't have much information on this. I would anticipate that during our next stakeholder group and meeting in August, VC will be here. They'll be able to give much more detail. The training, both of these trainings are currently projected to be completed sometime around June 30th of this year. Just because it's completed doesn't mean that that would be when it would be able to for participants to take the class. So there's still a lot of unknowns for me to share with everyone to give firm commitment on dates and classes, class registration. But we will be communicating a lot with everyone's regional coordinators once we have these things finalized and put in place. As I mentioned, I would imagine that VC will be here next stakeholder to give more information, as they're also doing an evaluation project on these, or a research project on these trainings. And then we're also finishing up our 911-988 interoperability. This is only e-learning. This one's really designed specifically for 911 and 988 to really strengthen the interoperability to help with some of those transferring of calls and understanding. So it also kind of works us through system roles and workflows, triage. Again, both seem to be completed around the same time, but there's level of complexities on what platform to host that on and how to get it out to the community. So yeah, stay tuned, as everyone always does. And then, as everyone has been aware, last year, the Behavioral Health Commission evaluated Mark Stiller and then just the overall crisis continuum. It was a pretty lengthy research, but we learned a lot of really good information, particularly about Marcus Alert implementation and how it aligns between crisis services and the civil commitment process. So some of the key things that they found were 988 interoperability, coordination, having more expansive of behavioral health only response or consistency with training, particularly for those Marcus Alert level 3s that tend to be the grayer area where they don't meet criteria for hospitalization, but there's something going on and they may still lack capacity. And funding flexibility and resource alignment. Again, data collection, all of this, I'm sure, because there was a lot of people on this call who were also a part of this research and were strong advocates in the interviews. But obviously there's still challenges that we experience and barriers with trying to get these different systems to work and coordinate together. So as a result of that, they shared that high-level priorities for DBHDS would be to improve coordination between PSAPs, hubs, and mobile crisis team, expand cross-jurisdictional co-response capacity. I know some localities do that already, but it would just be having co-response being able to respond to more than just their own jurisdiction. Strengthening the statewide infrastructure, right? So building out that Marcus Alert training and building out the interoperability training, reducing barriers to crisis facilities access. So we really need to push for no wrong door, and enhancing data systems to support evaluations and planning. So all of this informed ongoing planning for full statewide implementation, and it kind of leads directly into sharing relevant legislation and budget updates. So several bills and budget amendments were enacted based off of that research study. For Marcus Alert, these were the highlight. There were a couple other ones, but these felt most applicable to share with everyone. And if anyone who's been following the General Assembly crossover was last week, so right now all of these have moved on as of Friday at least. The original chamber and are under consideration in the opposite chamber right now. So we have the Marcus Alert system, external data base information removal. So that one's just saying that the localities would not be responsible for removing a participant from it once they turn 18, since as everyone who's on this call has been tasked with that, and they can understand and appreciate the challenges that come with trying to find that information since it's an external database. The other bill was having an evaluation task force. And that's where we would have the inclusion of looking at what KPIs for co-response are we currently collecting, and how do we need to change that? Are there any other implementation barriers and system alignment that we can make more feasible or easy to be accessed to. So it would be something kind of similar to this, where at minimum you would meet twice a year, similar cross-functional stakeholders as was originated in the state plan. And then the last one was to just have, as we're going through that evaluation task force, but to also have that be reflected in the state plan. So everything that had been determined or had been spoke of with this evaluation task force would then now be updated for the state plan. So that way every locality had a clear understanding about policies, procedures, and expectations that would help them with implementation. Um, and so again, we don't know what any of that would look like. That's just what the bills were saying in and of themselves. And then there were a couple other budget decisions. So a pilot exploration for PSAPs to dispatch mobile crisis teams, transitioning out of, again, that fixed 600,000 to a needs base. And then also the considerations for fully funding all of the CSBs, because we still have 13 sites that need funding. So again, I really want to put an asterisk that all of this is still in the legislation process. We don't have any more information that we can provide that isn't already available on LIS. And that's where I would encourage anyone who wants to get more involved in how things are rolling out in that legislation, or as it's moving through the General Assembly. But as soon as we know outcomes or timelines, we will 100% communicate and make sure that everyone who is a part of this work is being represented in all of those work groups. And as we think about rewriting that plan or task force, if it makes if it gets passed, that is. So. All right, and I apologize again. I did not update this. Didn't update the slide on before, but I'm going to go ahead and pass it off to Brianna Green, who's going to give us some important updates on 988. It's also her birthday, so I'm going to say birthday.
Thank you so much, Em. I appreciate it. And feel free to stop me if I'm talking for too long, because I know we have some other things to get through.
Yep.
But yeah, we can go to the next slide. Hi, everyone. I am Brianna Green. I'm the Director of Virginia Programs over at HopeLink Behavioral Health. Thank you all so much. Pisces season. I don't know if I have any fellow Pisces in the room, but it's our time to shine. No, I'm very excited to be here. So I oversee kind of the local or state side of our crisis services program here at HopeLink. You may be familiar with the fact that we also have a national side of the house. So just wanted to make that clear before I continue for anyone who might not be aware. So just some quick program updates since we last met as a group in this space. HopeLink's very proud to have successfully completed reaccreditation through ICH, or the International Council of Helplines. So now we are reaccredited for both our phone services and our chat and text, and then newly accredited, which is very exciting, for our mobile crisis dispatch services. So that was a new accreditation that became available, I think, in the past year. So that was our first time going through that. Definitely learned a lot, but it was also very helpful in terms of making sure we have the best policy and procedures for standards that are recommended nationally at this point. So huge win for HopeLink. Very happy about that, and that we can better support you all with that. I was very honored and excited to attend a state convening to discuss the statewide approaches to crisis response with our wonderful host here, Emily, some other DBHDS folks, and some other regional folks. And was hosted by the Council of State Governments Justice Center, and we went in Salt Lake City, so we got to hear from Washington State, New Jersey, and I'm going to forget the other one, unfortunately. Anyway, Utah, because we were in Utah. About how they are approaching crisis response as a state. It was really interesting. I know Emily and Kurt have a lot of thoughts that came from that, and we'll be sharing more as things maybe come about from that. That was fun. And then we, as a crisis center, transitioned to a new phone system on December 18th. As you can imagine, for a crisis call center, that's a pretty big deal. So we were very happy it was as successful as it was. Our staff are really enjoying the new system. It was definitely a positive change for them. And we are also, even though still getting to know a lot of the data available to us, really excited because there's a lot more real-time data that we have and that our staff has access to that they didn't in the previous system. So that's going to be an advantage for all of us in this room. We finally rehired a PSAP liaison, specifically for Region 2. So this position is kind of the in-between. She's an expert, or going to be an expert, in 988 operations and policy and what's required of us as a 988 center, but also really understanding what our PSAP, law enforcement, 911 partners need for us to make interoperability between 911 and 988 as successful as possible. So very excited to have someone in that role with such great experience, who's already a go-getter, and excited to get more involved. And then I'll touch on this a little bit more in the next slides, but some unpredictable volume trends across the state, but especially on 988 Virginia, which is where a majority of our volume comes from, but not all of it. So we can go to the next slide. Thank you so much. So this is all, the top chart is all inbound calls offered to HopeLink over the past half of a quarter or half of a year or so. So you will see a pretty clear trend. We were consistently increasing in volume across all of our lines between July and December, which will help some of the data on the next slides make sense as well. You'll see the same is true for our 988 Virginia chat and text that were offered to HopeLink. There was also quite an increase, almost double the increase between, or double the volume between July and December. That works a little differently than the routing does for phones. I'll explain it super quickly. If you're confused, you can email me later and I can expand on that too. But essentially, we are only offered what we're available to handle for chat and text. So because of the LGBTQ shutdown, and we had availability and funding for Virginia services, we were able to retain, I think, almost all of those staff if they chose to stay on 988 Virginia chat and text. So because we had such an increase in staff to answer 988 Virginia chat and text, we were being routed more of those in-state chat and text to answer. So there's always been a high volume for Virginia 988 chat and text, but we would answer what we could, and the rest would go up to the national backup chat and text routing network. So it's different with calls, because with calls is we get what's offered. We get, when people dial 988 Virginia, that's coming to us regardless of if we have people on queue or ready, etc. So regardless, lots and lots of volume coming to Virginia. And then we go to the next slide. Then getting more specific, of course, into our Marcus alert work here at HopeLink. This is average speed of answer. So this is how quickly our 988 workers have been able to answer transfers coming from PSAPs or 911 dispatchers in the respective regions. So you'll see, unfortunately, with the increase in volume that we were receiving, There was some competition because we have shared staff. We have shared staff across all of Virginia lines. We don't have, unfortunately, the funding to designate specific staff to specific lines. As a result of that, some of the average speed of answer for our PSAP calls did increase, though we are still under 30 seconds, which is very good. We want to keep that. Those calls are a priority to us, and they are still set as a priority in our system. So the first calls that are set to get answered, as long as there's someone available, is from the PSAPs, from our 911 centers. Then we go to the next slide. Thank you. And this is the volume. So we have quarter 1 and quarter 2 volume. Again, you'll see kind of the pattern with the answer rates. There was some decrease. We're seeing more of an increase now because 988 volume has decreased a bit. So we're, of course, monitoring that to make sure that we have what we need to continue to serve people as best as possible and be good partners, especially to our 911 centers who are doing such important work. And we also have more staff coming on. So we're working with a contracting agency. We had over 50 people who started in training this morning. So keeping our fingers crossed, we retain as many of those folks as we can, and we'll continue to see some really pretty over 90% answer rates here as the year goes on. Next slide. And I just wanted to recap some of our challenges and wins. I think most people in this room are probably aware of most of the challenges and the wins. I really wanted to highlight that we had some amazing collaboration, or have had some amazing collaboration, especially so far in regions 1 and 2. Of course, I'm sure there's more to come in other regions, but where we've had what we call familiar voices reaching out to both 911 and 988 a lot, taking up a lot of resources and capacity. And it clearly showed that there was a gap in the system, that this person had a need that wasn't being met in the traditional ways. So we were able to partner with the regions and the CSBs to do some outreach for these individuals. And in both cases, it was quite successful in decreasing the volume coming. And not because we didn't want to hear from them, but because we knew they needed a higher level of care than we were able to offer. And they ended up being open to that. So that is a really huge win, I think, of Marcus Alert and the system overall, that we can work together and people can get the care that they need and they deserve. Mm-hmm. So a lot of people see the number of transfers isn't as high as they expect in their locality. So I just wanted to point out like a few factors. It's not a failure necessarily. Obviously, we'll take all of the transfers we can get from 911, but there are things like in-house clinicians in some localities and the co-response teams that are dispatched by 911, not 988. That might mean that we're seeing less transfers than people would expect. In that same regard, we do accept transfers from folks, even if a response is sent to them from law enforcement or emergency medical services. So we can talk to them and keep them de-escalated while in-person response is on the way to them. And I think that's also incredibly successful interoperability for all. Mm. We know there's still some pushback with the community buy-in. I still hear some calls where the person really just wanted to talk to an officer, or like the next bullet point, they really just needed a ride to a hospital. And that's not something that a gap we've been able to fill yet, as a state. So there is some people who are like, nope, if I call 911, I'm looking for 911, and that's totally okay. Still a lot of education and awareness that we can all do together. And then, of course, our PSAP transfer lines remain the highest priority to be answered in the call center here at HopeLink. So doing everything we can to make sure, again, we're the best partners possible and serving the community however we can, whenever we can. Yeah. Thank you so much.
Thanks, Bree. I appreciate it. That was a lot of really good information.
Thank you.
And I am excited to see where we can keep going.
Me too.
Yeah. And okay, so now I wanted to again offer opportunities to those who are doing the on the ground in-person work to share how they experience being in some form of community care team platform, how they experience and interact with Marcus Alert, and to give them an opportunity to share. So first up, we will have Region 1. I will allow them, it looks like it's their care team in the Winchester Fire and Rescue Department. If you guys want to unmute yourselves and introduce.
Good morning. Can you hear me? Or I guess just to say good afternoon now.
Yes.
Okay. I apologize. I cannot get my camera to turn on, so it doesn't really matter, I guess, because you're looking at my slides. My name's Ashley Hoffman. I'm the Community Resource Paramedic and Mobile Integrated Health Program Manager for Winchester Fire and Rescue. Our program initially started in 2022, long before I came. And initially, that was to just help call reduction volume as a whole on fire and EMS. I came in mid 2024 and took over, and we kind of overhauled our program. So our mission statement here is we're dedicated to delivering collaborative, multidisciplinary, and person-centered services by connecting individuals in need with vital community resources and fostering awareness to empower their well-being. So our program, while we hit a lot of different social determinants of health, there was one thing that was very evident up in this region, and that was we needed a heavier focus on how mental health was being navigated in our community. We have not just a community of people with high mental health or behavioral health needs, but we also have an increasing homelessness population, which, of course, there's a lot of co-occurring factors there. Next slide, please. So to me, this is why it mattered as I began to do my due diligence when I came into the program. We had, not just myself, but also law enforcement, had a lot of repeated mental health crises calls that were really driving up our call volume. And a lot of those things could have been handled in a non-emergent way. A lot of these people, they lacked consistent access. So again, whether there's somebody who lacks transportation, especially with our homeless population, as well as even a cell phone to make their follow-up appointments with Northwestern Community Services Board after coming out of whether it's a state hospital or a local behavioral health unit. Here in our area, very little of the time does our EMS services actually transport the mental health person unless there's been like an overdose or self-inflicted wound, something that need medical treatment. We typically rely on our PD officers to do a lot of that transport for us, which they don't mind. Without those interventions, cycles of crises continue to occur. We have escalated incarceration rates, and the hospitalization, of course, that revolving door continues. Next slide, please. So I apologize. It's really slow on my end, but so the way I try to work with our program is early identification and intervention of these people in the community. My referrals not only come from fire and rescue field staff, but PD, sometimes people that are coming out of the hospital, some of our nonprofits, food pantries, um, and sometimes just our normal citizens that see these people walking along. If you're not familiar with Winchester, we're a town of about 30,000 people in 9 square miles. So everything's pretty condensed. So a lot of people involved with this population tend to see a lot of things. I'm also involved with our mental health or behavioral health docket through our court here locally. So that also helps me line up with certain individuals. I am CIT trained and actually just got my training cert. So I've started that this year. I've had a few other type of mental health certification courses. I am a trained paramedic of over 20 years. So I do go out with our police department at times and do some de-escalation techniques. Sometimes I'm by myself and having to do them just depending on what the situation is. But to me, the biggest component that's important is that post-crisis follow-up or post-care follow-up, because that's where a lot of our patients tend to fall off. Mm-hmm. So one of the unique things that I also figured out why here is that there is an inability sometimes for our law enforcement officers to get emergency custody orders. And a lot of that time is because it's more due to medical issues in nature versus them breaking the lines of the law of which they can apply. So this is where I say it's our informal co-response team, because this is really just on an on-call as needed thing. I'm only in the office 8 to 4:30 Monday through Friday. But if an officer doesn't feel like they have enough legally to do a paperless, they will call me out. I meet with the individual and then make that informed decision of, do I feel if there is enough there, and then go petition before a magistrate and get the paper form. And then once we pick that individual up, I then follow them to our CTAC at Winchester Medical Center. and do a proper handoff to our Northwestern pre-screeners that are there to ensure that they're getting the full information and then the full picture. The other reason I do that is because my goal is to follow them, not just upon the ECO, but if they were to get transferred either to the behavioral health unit at the hospital or get sent out to Western State or another mental health hospital, that way I can continue to follow them, because a lot of times a person's history or the other social determinants of health that come with that person are not being properly relayed. Rather, it's not coming through in records, or whether the person may not be the best historian or may choose not to share certain things about their life in order to best help them. So I also help our local jail here. I'll say local, it's a regional, it's the um, Northwestern Regional Adult Detention Center. So I work with their mental health clinician as well on some reentry plans. We have a lot of people, because of their unmedicated behaviors, that end up in jail and in and out. And he will a lot of times get them medically stabilized, both with medication, but then they have issues coming once they come out into the community, realigning with the CSB and maybe getting the ACT team in place so they can get medications, or maybe it's transportation to get to those services. Maybe they need assistance with the insurance or other benefits necessary. Depending on the client and who they are aligned with, I will do additional care coordination and navigation to make sure that they are seeking the correct providers and doing all of the right things. It's really important for me to collaborate with their care team, because if there are days when they don't show up or there are concerns out in the community, I have that ability to go out and check in with them and come back and report. And we do have ROIs in place with all of these patients that are also 42 CFR Part 2 compliant, on top of HIPAA compliance, just to make sure that we're protected in that manner. When it comes to discharge planning, as I mentioned earlier, I do try to work closely with the hospitals that have these individuals to make sure that they're fully aware of the type of environment and support or lack of support that these people have, and the things that we've seen in the past and patterns that have been created when they've come out of the hospital, whether it's a medication compliance or therapeutic issues or triggers. Maybe there's somebody that would be better well suited if eligible for like mental health group housing. And then also frequent utilizer education to reduce strain on systems. So we do have some people that do manage fairly well, but they do seem to call 911 often for either EMS or police for matters that you would consider non-emergent. So we do sit down and have some one-on-one time with them to educate them better, to reduce some of the strains on our system, so our emergency services, both law enforcement and EMS, can be freed up for those in our community. Next slide, please. So our community impact. So what we're seeing, without a lot of pertinent data as far as numbers, we're actually in the middle of switching up softwares to something more case management driven than what I'm currently using. But we have seen a decrease in 911 calls. And again, when I reference 911 calls, that's not just through EMS and fire, but that's also with law enforcement. I do respond when called for law enforcement diversion efforts. So these are people that maybe are unmedicated or not stable in our community. And I try to go out and de-escalate them and help them choose a path of seeking help and maybe going out to the hospital versus getting taken to jail. Improving that treatment compliance, whether it's me helping make sure that they're getting their medications, they're going to therapies, they're participating in the programs that have been recommended to them, working with our CSB's ACT team to make sure that they're finding that individual in the community to get their medications. We have seen increased stability for those vulnerable residents, again, whether it's helping them maintain a better baseline in order to be able to secure housing again and a job and be able to function independently in the community, or is it a better suited environment of a group home setting maybe. Definitely one thing that has been a big bonus of this program that I felt like was lacking initially before I came along was interagency collaboration. So quite often, so many people are involved in somebody's care, and not everybody realizes who all is involved. So there can be some service overlap there, or sometimes we're working against each other. So my goal is to do as much research and find out as much as possible so that all the people involved even if it is a social services case manager, along with their case manager at the CSB, maybe their primary care, their therapist. All of us need to be involved to make sure that we have a more synergistic approach for long-term success with these people. Again, it provides cost-effective and preventative care. Obviously, the more we're getting involved, the more prevention, the less burden of cost, not only on the system itself, but also for that person. Some of them that don't have insurance or may not be eligible tend to not want to seek care because they can't afford those bills. And then enhances public safety. Again, here in Winchester, while it's not terrible, we do have some people that are homeless out in our community that tend to like to wander around. And sometimes some of those behaviors can be quite concerning and not just self to harm to themselves, but also to others. So that's the real big push behind our mental health program within the CARE program. Next slide, please. So again, identifying our service gaps. For us up here, we do lack a lot of transitional programs, and I think we're trying our hardest to try to identify that as best as we can. Again, unrecognized social determinants of health. Some providers get very siloed in what they're taking care of with these people, and they're not looking at the full impact as to what's needed for that person. So we kind of need to look at them holistically, not just for that one specific problem. They also get reentry assistance, like getting them set up with a new phone, transportation, making sure that their appointments are being scheduled, that they're attending them. Medication compliance, I do meet with them, but also making sure they get aligned with certain programs that may assist them as well for extra accountability. There's also, again, with our homeless population, the difficulty of being able to locate these people. So me being the boots on the ground helps with that. And then also, again, bringing that external environment information and what a day in their life or what weeks in their life look like out in the community versus when they're in a controlled setting looks very different. So it's very important to me that I am able to exchange that information with who's maybe taking care of them on a whether it's an inpatient admission or even outpatient as they continue to do their care planning. Next slide, please. All right. So from our program in the beginning overall, and this is not just mental health, this is all the other things that we do too, because we look at everything from our aging population, complex comorbidities, mental health, and substance use. But of those 505, 276 of those include mental health. And some of those are just very minimal needs. 20 of those are dementia, Alzheimer's, 84 were homeless, and 50 of them had substance abuse as well. 70 of those, their primary and significant medical condition was related to a mental health diagnosis. Next slide, please. So for our growth, we are working on a co-response model MOU with Northwestern CSB right now. It's in its infancy stages. We are adding, as I mentioned earlier, a new software called Gelato, which is case management. And if you operate in an area where somebody's using that, I would suggest that you look into it. If you just Google them, I don't think the website does it any justice, but what that software allows us to do is to be able to collaborate as a community, not just as an agency. And it's very beneficial because it's giving us impacts in real time. So I know if somebody ends up having a law enforcement encounter and goes to jail, I will know if somebody's been admitted to the hospital. It really cuts down on a lot of the time that it takes sometimes to get phone calls back or be able to reach those people. And then as of today, I finally, thank goodness, I was a one-man band until today. I've hired a full-time EMT as well to work on my team. And his name is Cedric. I'm very happy to have him. And I only look for our program to continue to grow. Next slide, please. And then there's my information. If you want to scan my QR code, that will download a contact right up into your cell phone on ways to get a hold of me. Our phone number, my cell phone number is also posted. And then that referral link, if you click on that, that just tells you a little bit more about our program and then also has a place where people can do referrals from the community.
Yeah, that's great. Thank you so much, Ashley. I appreciate that. That was really good information. And just to reiterate for everyone, I will share the PowerPoint. So all of this you can have access to through your regional coordinator. All right, so we will pass it off to Region 4. I know that I believe there's two teams that both had their own success story that they wanted to share.
Yeah, I can go ahead and introduce them. Before doing so, Emily, I did just want to flag in case you didn't see, there were a couple questions in the chat going back to what you were sharing about the training and then the data. Do you want to table those till the end, or would you rather address them now?
Yeah, I appreciate it. Thank you. I can't see what's happening in the chat right now, so I'll address it when we do questions at the very end.
That's great. Alrighty. Hi, everyone. I am the Mark Split Coordinator for Region 4. My name's Hannah New-Craig. I'm just going to go ahead and introduce a few folks who'll be sharing out, so kindly and generously sharing out 5-minute testimonies or experiences on their working on the front line. I'm going to start with a couple of folks from the Richmond co-response team. Their team is called Community Response Team, CRT. We have clinician Ariel and then Officer McDonald on the call who are going to share out a bit about their experiences. So go ahead and take it away, y'all.
Hi, thanks for the introduction. My name is Ariel. I'm the clinician for the co-response team, and we have had a lot of opportunities to kind of divert from hospitalization. So we have 5 different hospitals in Richmond City that we will triage and try to bring to our clients to their different EDs. But also a main point is trying to divert away from those. So we're very lucky to have our community response and our crisis continuum with CREST, our REACH program, which helps with ID and autism. We also have our community stabilization unit, our crisis receiving center. And as the clinician, trying to figure out where we can meet the client's needs in that moment while they're going through that moment of crisis and collaborate with our emergency services department to make sure that they get the help that they need and not so that they're cycling in and out of the hospital. And riding with Officer McDonald, he and I have created a good relationship with our community members that we might see fairly frequently, and then the ones that we don't see very frequently. And a success story that I'd like to share is we had a gentleman who had attempted to hang himself, and we were able to connect him and safety plan him with community resources. So instead of having him go straight to the hospital, any just as a safety plan, we were able to connect him with his partner, with friends. We were able to have him stay with several people and vouch for his care, and then make sure that he had the crisis resources. We have a little pamphlet that we have out. So his friends were able to contact those resources to make sure that he also was not alone in trying to figure out the mental health system.
That's amazing. Thank you.
Thank you so much, Ariel. And I want to give an opportunity, Officer McDonald, did you want to chime in as well with anything?
Yeah. Hey, everybody, I'm Officer McDonald. Yeah, I think Ariel covered most of it, but I think looking at this from a policing standpoint, taking some of the pressure off of our patrol units through calls for service, as well as just the ability, I think, to de-escalate in a different way, in a better way. Coming there as a team has really helped the Richmond community as well. Since I've been on patrol, I've been with the department for about 7 years. I've definitely seen an increase in these types of call for service. And in a sense, we're kind of a catch-all because a lot of calls might contain those subject or people that have mental illness. And I think approaching it in this way has really helped decrease either the relationship between the community and police officers, decrease the stress from that, as well as the possibility for use of force as well. So just from that side of things, it's been interesting to see the change and the differences in the way we respond versus patrol units.
That's amazing. I really appreciate that. Thank you guys for sharing.
Absolutely.
Yeah, thank you both so much. And I appreciate both the law enforcement and clinical perspectives there. So thanks for the good work that y'all do every day. Alrighty, and now I'm going to pass it off to Luke and DA, who are both peer recovery specialists from Henrico. They work with the Henrico mobile response team. So thank you all for joining. I'll go ahead and pass it off to y'all to share out.
Thank you, Hannah. So my name's Luke. I'm a peer recovery specialist with the mobile response team for Henrico Mental Health. I do a few things as a peer for mobile response. I ride with police. We respond to mental health calls in the community. I offer peer support during that process. Normally what that looks like is the clinician will get into our evaluation, and if it's looking like there's maybe not criteria, then we'll find a good moment for me to step in and try to offer resources in that moment. We also perform follow-ups to every pre-screen that our clinicians perform as well. So normally what that looks like is we will wait a few weeks for the discharge from the hospital to take place, and then we'll reach out with a phone call to try to connect them to services and get them connected to resources. We'll call 3 times. After 3 times, if they're not picking up the phone, then we'll stop trying to outreach at that point. Also, we go to the crisis center, our CTAC. So that is our assessment center in Parham Doctors Hospital. So we go and we offer support to folks that are experiencing crisis and are currently being held under TDO at that location. We also serve on the STAR team. So STAR is a partnership between APS, CPS, building inspection. We have police, fire, and mental health. And basically that is just us sort of keeping tabs on folks of interest in the community as it relates to mental health. Maybe discussing plans for getting people connected to resources, hopefully before a crisis takes place, and seeing what we can do to hopefully prevent that as well. And that is basically mostly what I do. I know DA he works with the veteran population, so I'm gonna let him talk about his role a little bit more.
Hello, everyone. My name is DA, and I'm sorry, there's an echo. My name is DA, and I am a veteran peer. Are you able to turn? Yeah. Okay. I'm going to say it the 3rd time. My name is DA, and I'm a veteran peer within Henrico Mental Health. So I pretty much do majority of the things that Luke talked about, except my role is tailored towards veterans. When we go out into the community, my job is to basically, identify with the veteran, share my story, but also get them plugged in with resources other than the VA. Nothing wrong with the VA, but the VA is not for everyone. If you're a veteran, you understand. And so my job is basically to see what they're looking for as far as resources and get them plugged in with that. I'm also heavily involved with the Veterans Docket. The Veterans Docket was started, it was started out state, but Henrico has adopted the model. And basically what it is to help veterans in the community who have gotten in trouble with the law to go through a program that's aimed at helping them learn about what they did as far as addiction, mental health. And my role in that is basically to facilitate group. And I talk about my experiences, and we also talk about coping skills. We talk about addiction and what that looks like in our lives. We talk about all different sorts of things. And so, my role in that is to just help people, look at what they did and try to figure out a solution on how they're basically not going to repeat what they just did, right? So I'm heavily involved with the Veterans Docket. I also facilitate group at Henrico Jail West. Basically the same thing, but it's for people who are currently incarcerated. So that's basically what I do. I don't just work with veterans, I work with anybody. So don't just think I'm just here for veterans. I'm here for anybody that's dealing with the mental illness or addiction. So
Mm,
that's my role.
that's great. Thank you guys. Thank you both for sharing. All right. Anything else from Region 4?
Okay.
That's it. Just wanted to again thank you, Luke and DA. Thank you, Ariel and Officer McDonald, for representing Region 4 and just for the tireless, amazing work y'all do every day. I'm always so humbled when I get to witness the great work that y'all do. So thank you so much.
Yeah. Yeah. And
Thank you.
I really appreciate you guys sharing your guys' roles and how it shows up, right? Because it's really challenging to figure out how Marcus Alert operates because it varies by locality. So I think it's great for you guys to share your specifics. All right. And we will move forward to Region 5.
Hello, everyone. I am Claudia Horner, and I am the regional liaison for Region 5. And I am going to have success stories shared by Casey Mewborn, who is the Region 5 Hub Supervisor. He'll tell you about a collaborative approach to answering calls across our region. And we'll shine a light on one of our locales, Hampton Newport News, with Connie Vatsa, who is the Marcus Alert Coordinator for their CSB.
Great. Thanks, Claudia. And Casey's ready for you whenever you are.
Sure. Ready?
Yep, I'm here, Casey.
All right. All right. So in Region 5, we've been collaborating with our Marcus responders from the hub. So Connie was one of the first programs to reach out with Hampton Newport News CSB and their Marcus team. We wanted to see if we could get more robust response. We were seeing some issues, whereas our communities were not getting enough of the appropriate responses. Sometimes they were calling and they were only getting offered some financial resources and not the behavioral health resources they needed. So we developed a plan to work with more. Our hubs were being bogged down with this. So we've reached out to our Marcus teams, and they brought themselves into the VCC and allowed our dispatchers to dispatch them out to some of these high utilizers of service and these types of calls. So in the last 12 months, we have 273 Marcus dispatches throughout our region. They're 100% behavioral led responses, not co-responses. No formal co-response model needed. They've expanded the hub's capacity through our collaboration. Go next. So we were able to, of course, to divert from law enforcement response, improve stabilization for the repeat and high utilizers of service. And then, of course, regional integration support model. Again, Connie's team was the first one in, and then followed up was Norfolk. Norfolk's Marcus is in there now, responding to calls, and Virginia Beach also assists in their region, or in their area as well. So this again helped us improve our engagements with our high utilizing individuals, reduce system fragmentation across jurisdictions, and the model supports sustainability and scalability across the regions. So we were able to give let me pull up. For 2025, we had a total of 8,507 dispatches. And again, as we work to develop this, our Marcus teams responded to 273 of those throughout the year. They came in through various times throughout the year. We continue to see each month increased utilization from our Marcus teams in the VCC. Again, preserved officers' accountability for criminal and public safety matters, taking them out of the loop for these lower acuity calls. And of course, we're able to maintain safety for our responders utilizing our dispatches and our check-ins. We improved the call triage at the hub level. So again, we are trying to reduce our repeat callers, keeping them out of patrol involvement, strengthen our partnerships between our CSBs and our PSAPs, and enhance the confidence in the behavioral health led response model. This also helps us again try to cut down on some of our fraudulent calls, people that are seeking monetary resources over behavioral health resources. This has been a huge impact that Connie's team has given, as well as our other Marcus. Our hub responders can only respond to so many responses, especially as we're trying to keep the repeat callers that are simply, when they call, they say, hey, I want a hotel voucher, or I want a gift card, things like that. We know that if we give that to a private provider, that they're more than likely to get that response and get that resource. And they're just going to continue to utilize the system to get that. So we try to make sure that they have the appropriate response for what they need by utilizing our hub and our Marcus teams. And I'll let Connie jump in here, as they were the first.
Yeah, so we at the Hampton Newport News Community Services Board, like Casey said, we do have a Marcus Alert team that can respond to those dispatches from the Regional Crisis Hub. We also have community care teams in both of our cities, and our Marcus Alert team with the CSB can co-respond in the community as well. We get calls directly from dispatchers who are responding police out. We can meet them on scene for those level 3s when neither care team is available in either city, and we have hours outside of those care teams' availability as well. We've been able to achieve up to 10 days each month since December of 24-hour coverage of those co-response teams. So we're finding a lot of good outcomes. The teams have a high percentage of keeping individuals in the community, developing safety plans, and overall it looks like 10% or less of our evaluations result in an emergency custody order. But there is a specific interaction that our Hampton Care team had recently that I would like to highlight. The sister, who is the caregiver of this individual, had called 911. Sister had a long history of schizophrenia, had been able to live independently most of her life, but as she aged, she had moved in with her sister. On this particular day, she was insistent that she wanted to go to the bank. Sister wasn't able to take her right away. She left the house in her house coat and slippers and was walking to a bus stop that didn't actually exist. The care team was able to catch up with her about a quarter mile to about half a mile from her home, engaged her, built rapport, really spent some time with her, and eventually the woman did allow the care team to walk her back home. And so I know that the sister, I was planning to take her to the bank later. But really, that care team did spend some time with her, and the clinician did follow up with the sister the very next day, making sure she had the information for the regional GERO community stabilization program. And the sister was so appreciative of everything that the care team had done and had followed up with her that she did agree to be interviewed for a local news station for a story that highlighted our team. So that is one of our success stories in Hampton Newport News.
That's great. Yeah.
Absolutely. And some of you may be thinking, wait a minute, if the hub is dispatching out the Marcus teams, and how are the localities able to use them? Great question. We have a standard procedure, whereas if we place Connie's team on a dispatch, and unless they're on scene with the individual and dealing with the individual, if they get another call from the actual PSAP saying, hey, we need your team, they can then cancel while en route, and our dispatcher will then pull them off of that, and then find someone else to go to that response and get someone else to that. We definitely want to make sure that each locality has full access to their Marcus team. We're just trying to help utilize them as well to make sure they can get out in the same community. And of course, we don't dispatch Connie's team outside of Hampton or Newport News, right? That's their jurisdiction. That's the only places we ask them to go. We try to keep each one of the teams, when they do respond, in their localities.
Yeah. Great. I appreciate that. Thank you.
So again, guys, it's the same thing we've always been preaching: the right response, the right resource, the right time. We want behavioral health led response, which strengthens our systems. And then we want our public safety to be able to know that these cases are getting handled, and they're there to back us up, but they don't have to take the lead in them, right? We are very big into our regional collaboration, which helps strengthen the Marcus Alert and the 988 system. Our model definitely demonstrates measurable, sustainable system impact. Super proud of all the hard work that our Marcus teams are doing, and all of our mobile teams.
Yeah. Yeah. Thank you. Thank you. We agree. I really hope that everyone on the call appreciates hearing as well what's happening in the localities, and seeing how we're able to move people through the system to get them the care that they need and address these service gaps. And I think your guys and everyone, Region 4, Region 1, thank you again. Because I think it shows how you guys are working and getting that done. So we really appreciate it. We will transition to just regional updates. I'll pass it over to Erica, who will give you updates for Region 1.
Emily, you can just jump right on to the next slide. Hi, everyone. I'm Erica Besley. I'm the Region 1 Marcus Alert Coordinator. And so I'm going to give you some overview of what's happening at each of the implementing CSBs, and then what's happening with those folks who are getting ready to start. So I always like to start with a map. I am not a native to Virginia, and so I always like maps so I know where we're talking about. And so this is a map of our region. As you can see, looking at it, all of our implementing and planning CSBs cover multiple jurisdictions. They have several counties and many cities and towns within them that they are partnering with on their implementations, or if they're planning their plan. So you can move us to the next slide. And in addition to, each of the implementers, our regional office does a lot of support for Marcus Alert across our region. All of the mobile crisis teams are coordinated and dispatched through our regional office, and that regional office is housed in the Region 10 CSB, which is in Charlottesville area. They also have taken the lead on Protocol 2 because they are the crisis call center contact. So when we need to work with our 911 centers and 988 together, our regional office is our point person there. And we've had really good collaboration across our region with 988. It's been HopeLink has been fantastic when we've encountered concerns and issues. It's been actually a delight to resolve challenges. You can go to the next slide. So our pilot program was Encompass, and they've been, kind of shifting and changing and building their programs since December of 2021. When they came on board, they had a co-response that they had already stood up previously in one of their sheriff's offices. Their co-response is now expanded to 3 sheriff offices, 2 police departments. The hours have extended. They're responding to level 2 and level 3 calls. And their model is a mental health co-responder meets a CIT trained officer at the scene. And then if they're not on duty, those agencies can communicate and ask for the co-responder to follow up the next day with folks if it's appropriate. So also, initially, we had no mobile crisis in our area. We didn't have any regional mobile crisis, and we didn't have a local mobile crisis. And since that time, we have regional mobile crisis, and we also, Encompass has stood up their own local mobile crisis as well. And that's operating 8 to 8 across the entire footprint of the region, which is 5 counties.
Sorry,
That's okay. We also have an overdose response unit that supports families and individuals who have had overdoses, and they respond to them and follow up with them within 72 hours. And those are our folks that are going out and responding in the community. We have the mobile crisis, the co-response, and our overdose response unit. There's also a place for folks to go. It's a peer recovery center. And I've talked a ton about that in previous presentations, but the important thing to remember about the C Center is that it's no cost for services. It's a drop-in center. And so that can be an entry point for a lot of folks to begin to get some of their needs met. And Encompass also operates a CTAC center as well. One of the things that I really want to highlight is that all of those response teams that I talked about, they all have a universal foundation in that they all go through the 40-hour CIT program. And so that allows folks to get up to speed on the resources that are available, and it also allows the people who are responding in the community to mental health to have a level set base, as well as to get to know each other in that situation of doing CIT. Many of the folks who are in these response situations have gone on to become CIT instructors as well. So it's really the universal foundation and Encompass for all of these response teams. You can go to the next slide. So in Rappahannock area, again, these folks have been, they were the second implementers, so they've been going since July 2023, and a lot of changes have happened there as they see what works and what works great and what, you know, what things they need to add. Excuse me. Within their footprint, they've always had the Sunshine Lady House, which is the crisis stabilization unit for adults, and that's open 24 hours a day, 7 days a week. But over the last year, they have added crisis stabilization services for children, and those are sometimes referred from level 2 calls. And those services are staffed by a licensed therapist who's also a certified pre-screener. And the service can be provided in the office, or the therapist can go out into the community to do that work. And it's available Monday to Friday. They have operated a co-response team from the beginning. It started in one jurisdiction, but now it's operating in Spotsylvania County and Stafford County, and there's a third position being hired for Fredericksburg PD. The hours vary across the different jurisdictions based on what those jurisdictions see as their primary need, but the mental health co-responder works 40 hours a week at each of those locations. And in this model, they are riding along with officers to the calls. And they provided me some numbers to share with you. So from July 1st through the end of January, Spotsylvania County had 175 calls and Stafford had 199 calls. So they supported 374 folks through their co-response program. You can get, oh, almost forgot. They also have, they're developing a crisis receiving center, and they're anticipating that will open in spring of 2027. So it will house a lot of the programs that I've just talked about into one space. So it will co-locate emergency services, their CTAC center, their crisis stabilization therapists. They'll have 23-hour observation, and then they'll also have residential crisis stabilization there too. So it is an exciting development, and we're looking forward to it. You can move to the next slide. Thanks. Horizon's been implementing since July of 2024. And since I was just talking CRC, they have a CRC that's opening in May of 2026. So they're in the midst of inspection and licensing and credentialing, and they've got several staff hired. So that's exciting. It's been in the works since I started working with them on their planning process. So it's been a long haul, and it's very exciting that it's going to be opening. Horizon has been operating co-response with Lynchburg PD since they started their implementation, but they have recently expanded, and they have a new mental health co-responder that's hired to work with Bedford. And so, again, the hours are going to vary across jurisdictions based on the need. They also have developed local mobile crisis, and that's been continuing to expand. They have new staff that they've recently hired, and once that newly hired staff completes their training, their service will be able to expand to 7 days a week, and the hours will be 8:30 to 9. In addition, they have a community response team, which is mental health workers, no law enforcement, that's responding to referrals from first responders. So they go out and meet with folks within 48 hours after they receive the referral. And it's a peer and clinician team. And they'll provide assessments for folks and then linkages to long-term mental health services. Okay, so you can switch slides. The last two CSBs I'm going to talk about are Northwestern and Valley. They have been in the planning process, and they're got their plans submitted and are ready to get going for July 2026. A couple of exciting things. You actually heard from Ashley at Winchester Fire and Rescue. So Northwestern is working, they had that program, and they're working to incorporate that program into co-response with mental health. So it'll wrap all those together, and that's exciting. And it was new. This is the first in our region where we've had paramedic co-response explored. And then Valley CSB, what I have been super excited with there is they had their mobile crisis team, local mobile crisis team already up and running. And so it was awesome to have those folks deeply involved in the planning process. And Valley has, despite having some really small law enforcement agencies within their jurisdiction, all those law enforcement agencies, despite their size, are fully participating in all of the protocols. And so that's really exciting. And I can't wait to share more with you guys at our next several meetings as these folks really get going. There's a lot of exciting stuff planned.
Yeah.
And then my last slide is just for you all. Contacts. I talked about a lot of different programs. If you have questions about those programs, these are the contacts at each of those agencies that are up and running, right? Where have Marcus up and running. right now, and you can contact them for specific questions about programs if something piqued your interest. Those are going to be the folks who are going to be able to answer a depth of questions. I'm just a talking head.
No, you're not, Erica. Don't do the stuff. You do a lot of work, and we appreciate it. Thank you. Thank you. That was a lot of information, and it was a lot of really good information. And I hope it helped others, especially again, as we're thinking about those who are still left for implementation, some of the different team compositions and how you can make your localities work for you. So I really appreciate that exciting stuff with Region 1. And I will go ahead and pass it off to Region 2.
Good afternoon, everyone. My name is Stephanie Pryor. I am the Marcus Alert Coordinator for Region 2, which is our Northern Virginia area. All of our CSBs and localities have implemented Marcus Alert. Some are in their second year of implementation, some are in their third and fourth years. So I'm going to be providing more of an update on some of their crisis systems since our last meeting. So go to the next slide. So City of Alexandria, go next slide. City of Alexandria implemented Marcus Alert in July 2024, and it continues to expand its efforts. This includes the expansion of their post-crisis outreach team, which launched in November 2024. In 2025, the team served more than 175 individuals by providing resources, referrals, and connections to services. And over the next 6 months, the team plans to expand its referral network to include police officers and fire department. So that's been one of the biggest changes in City of Alexandria. Arlington County. So you can go to the next slide. Arlington County implemented in July of 2024 as well. It continues to expand their crisis services. Their mobile outreach support team, or known as MOST, is now fully staffed with 2 teams and clinicians and have completed pre-screen certifications. The service hours have expanded from 8 a.m. to 9 p.m. on weekdays, and teams are trained to support individuals across all age groups. Their emergency services is now fully staffed for the first time in over 50 years, resulting in a significant increase in community-based evaluations, which is now approximately 40% of all evaluations. The Crisis Intervention Center, their CIC, has added 24/7 nursing coverage and a full-time prescriber, which is contracted 24/7 for telehealth services, and they're scheduled to begin in March of 2026. The CIC has also implemented acceptance of transfers of custody utilizing special conservators of the peace and improving coordination with law enforcement and continuity of care. And then the Mental Health Criminal Justice Review Committee, the MHCJRC, it's a huge acronym, in Arlington, finalized a comprehensive strategy plan aligned with the sequential intercept model addressing community services. So following that, Intercept 0 law enforcement, Intercept 1, initial court hearings and detention is Intercept 2, jails and courts, Intercept 3, reentry is Intercept 4, and community corrections is Intercept 5. So lots of really great work in Arlington County. We can move on to Loudoun. So Loudoun County also implemented July 2024, and they continue to strengthen coordination across their crisis systems. Key updates since we last met, cross-training, they had invested in cross-training initiatives. So cross-training is underway between emergency services and co-responder teams. The effort equips staff to perform functions across both service areas, improving program coverage, enhancing staff skill development, supporting staff retention, and promoting stronger collaboration between law enforcement and crisis services personnel. They expanded their co-responder hours. So effective February 2nd, co-responder team hours were expanded from 1 p.m. to 9 p.m. Monday through Friday to 11 a.m. to 9 p.m. Monday through Friday, including holidays. And this increased service availability and response capacity. They also invested in their CIT program. So Their crisis intervention team training has been moved under their crisis services department. This change strengthened the coordination and partnership between law enforcement and Loudoun County mental health, substance use, and developmental services, and an enhanced patrol officer education regarding available crisis resources. So that was a really good change in their region or in their county. And then they are working, or they have their crisis receiving stabilization center. So they're working on it. Substantial construction of their CRSC facility has been completed. The county is actively reviewing RFP responses to identify an operator and is currently recruiting a contract administrator. So the facility is hoping to open summer 2026. And then they also invested in their PSAP coordination. Staff are actively working with their primary PSAP to ensure monthly data accuracy and support ongoing program evaluation and coordination. Okay, and in Fairfax, Fairfax County implemented July 2023. They continue to work closely with their PSAPs, Fairfax Falls Church CSB, and regional partners to support community needs. The county continues to emphasize interoperability between 988 and 911 to improve coordination crisis responses. Fairfax County has also collaborated with community partners to review cases involving high utilizers. So some of those cases that Bree was referring to with those, familiar voices, they've done a lot of case staffings to try to find solutions forward. So a lot of case reviews for those high utilizers and emergency services, and they've also updated safety equipment for enhancing the effectiveness and safety of their co-responder program. Okay. And then Prince William, which was our first jurisdiction to implement, which was July 2022. They've continued to strengthen and expand their crisis response systems. In fiscal year 25, the county transferred 944 calls to the regional crisis call center, with an additional 883 calls transferred so far in fiscal year 26. Through outreach and in their engagement team responses, 625 individuals were served in fiscal year 25, with 300 individuals served to date in fiscal year 26. The co-responder program conducted 845 responses in fiscal year 25 and has completed 442 so far in fiscal year 26. And that has demonstrated continued utilization and engagement across their entire crisis response services. Next slide, some other changes in Prince William. Prince William opened its new crisis receiving center in October 2025, with these services beginning operations in January 2026. Since opening the center, it has served 437 adults and 90 youth. The county has also reported a reduction in out-of-area TDO placements and 43% from 43% to 8%, as well as 66% reduction in local emergency room wait times, reflecting improved access as well. Prince William continues to prioritize staff training and professional development. In July of 2025, co-responder teams participated in a live training conducted in partnership with their community services and the Prince William County Police Academy. The training included classroom instruction on nutrition, tactical emergency casualty care, and equipment refreshers. The afternoon session included role play scenarios and tracked exercises to provide exposure to high-speed driving and riding conditions, which is kind of cool, further enhancing their preparedness and coordination in the community.
Yeah, that's great.
And,
thanks. Oh, sorry.
Nope. The last slide is just my contact information. If you have any questions about the information that was provided this afternoon, feel free to reach out to me.
Yeah, I appreciate it. Again, it's really amazing to see how all of these localities keep changing. And I'm excited. Thanks for sharing. And we will go ahead and keep moving along, and I'll pass it off to Tony, who will talk about the updates for Region 3.
Hey, good afternoon, everyone. And greetings from snowy Region 3, where we're happy about hockey, but we cannot handle snow. I'm going to take a turn for a second. I start every day with a thought for the day, and today's thought was really appropriate for Region 3, so I want to share it. Champions always find a way, no matter the challenge, they adapt and thrive. That's Region 3 in a nutshell. And I want to start out with Blue Ridge so you can advance the slide. These will be listed alphabetically for everybody who's implementing fully, so you can track where I'm going. Start out with Blue Ridge, which is our largest catchment by population. Craig County, Roanoke County, Botetourt County, City of Roanoke, City of Salem, Town of Benton, and I'm sure I've left out somebody. They have 5 full-time clinicians. They've got 5 jurisdictions they're covering. That coverage area, as you can see on the screen, most days 5 a.m. to 1 a.m. One of the things I want to highlight with them is that third bullet point. The increase in calls of service from the Virginia State Police for co-response through partner jurisdictions. As you know, the state police aren't in the Marcus program, but they've heard such great news from the things that are going on in Blue Ridge that they reach out when they end up with what would be a co-response case. They reach out through partner jurisdictions for a behavioral health response, which is tremendous. And as Mandy points out, I've stolen Mandy's words, Mandy Lee, positive interactions with these individuals in crisis that wouldn't have had access to a therapist if it were just the VSP responding and this resource wasn't available. Partnerships are big in Blue Ridge, like they are in this catchment everywhere. They continue to partner with their law enforcement agencies to train their clinicians. They've also got a really good working relationship with the police academy, and they're trying to include a scenario or two during Officer Survival Week in basic training that would include clinical staff or a clinical response. If you would go ahead and advance. Mandy also produces a newsletter to keep the catchment advised of what's happening. This is a snapshot of their newsletter, just a calls for service piece, but it's a good way to keep their partners informed of what's going on quarterly, and kudos for those efforts. If you would, next slide. Danville, Pittsylvania County, who they are in implementation phase. They've submitted everything and they're ready to start getting some feedback, and they're ready to start training. They hope to be up and running. They will be up and running July 1st. I've included their 2 logos that are going to be on the sides of cars. The first one being their co-response team logo, and then their second one for 988. What they're going to look like is 2 teams operating 12 hours a day, 7 days a week. They're going to have 2 primary clinicians, a peer recovery specialist, and 6 PRN. The law enforcement component of this, both Danville PD and Pittsylvania County have identified their law enforcement staff for co-response. Go ahead, next slide, please. And they've strengthened their partnerships with their law enforcement partners and the school system as well, and their local hospitals. The sheriff's office has helped some with hosting a hostage negotiations training that the CSB clinical staff attended. And it was a good way for them to see what makes up the decision-making process in these intense scenarios that they deal with. And it increased their knowledge of how these decisions are made and their understanding of why, of course. And Pittsylvania County has also sent their co-response deputy to a youth and adult mental health training seminar. They found that very helpful and very enlightening, especially as they enter into starting this program. Next slide, please. Highland CSB, they are now up to 3 teams, 2 full-time clinicians, 1 full-time peer, 8 clinicians trained via co-response or PRN work, 3 full-time officers, 2 from Washington County, 1 from City of Bristol. The City of Bristol one is of note because it is an in-kind contribution. Originally, they started with 2 teams, which was all Washington County supplied. And the City of Bristol came on board. They liked what was going on. They said, can we give you an officer? And so naturally, Highland CSB accepted. And then Highlands also gave them in kind the clinician spot. Mm-hmm. So that 3rd team is all local pay, local match. They have 10 officers trained as who are CIT trained, who fill in for co-response PRN in this catchment. One of the big pieces for Highlands this quarter or this half of the year has been training. They dove into a thing called ICAT training, and it's geared toward law enforcement, but they found that it's benefiting clinicians. ICAT is a national program designed by the Police Executive Research Foundation, stands for Integrating Communication Assessment and Tactics. And it teaches officers to recognize behavioral health issues early, to slow situations down, use communication and positioning as opposed to force, to reduce the stress on the situation so that CIT component can start to kick in. It is almost like a pre-CIT training. Highlands got in big on this. They sent some of their staff who have a law enforcement background to the training as instructors, and they also hosted and have been hosting this training for other law enforcement agencies in this catchment. So that's pretty exciting. Even if they don't have a clinician with them, they're trying to get the officers to slow things down a little bit. Next slide, if you will.
Yeah.
The other thing that they're really excited about is the relationships they built, not just in this region, but outside. They were contacted earlier this year by Boone, North Carolina, who's trying to develop a co-response program. And Boone has been with them a couple times. They've come over for training. They actually rode with the city of Bristol. They followed them around. So they're trying to develop their best practices, and they're using Highlands as a model. Highlands is also developing a physical fitness standard for clinical personnel who are doing co-response, recognizing that some of the situations that they may be in because they're so rural require a clinician to be able to run, move, hide, whatever. They recognize that they probably should be a standard in place. They're working with their attorney to formalize and make sure that those meet the necessary protocol and legal hurdles. Hopefully they'll get that going in the next 6 months. They are in the process of trying to find training for their teams, specifically crisis negotiation training. And they're also working to create a crisis negotiation team within the boundaries of their MOU to enable select officers who have experience to respond in the needs of negotiation if a law enforcement partner should need it. Next slide, please. We'll go to New River. Montgomery County, it's New River's a very large catchment. As you know, they have Virginia Tech. They also have Radford University. They have the town of Blacksburg, town of Christiansburg, city of Radford. They're running 4 teams, providing coverage 14 hours a day in Montgomery County, 7 days a week. As you see, Montgomery, Blacksburg, and Virginia Tech. Radford was not mandated, but they're running a team in Radford as well, or a clinician who's embedded with the PD. Radford University is touting 100% CIT trained officers. They had a law enforcement and RU's campus for their response because they have a very low volume of calls at Radford University. They're still training and looking for more training. One of the most important things for New River is they are full staff for the first time in a while. And so they're really happy about that. They've got some people back who are deployed. If you would, next slide. And that takes us to Piedmont. Piedmont, they got shortlisted. I think they were called in October and said, congratulations, you're on the clock. And they have done a tremendous amount of work in a very, very short period of time, including a period that we had to place the director of emergency services on injured reserve because she broke a few bones. So they're in their budget year. They're proud of the feedback and the participation they've gotten from their partners on such short notice. They got their PSAP directors together early, trying to make things as simple as possible for the mandated piece that they have to do, and also to make the language for the clinicians as clean as possible across multiple jurisdictions. They plan on having 3 teams. 2 will be co-response and 1 will be that DSS response model. They're trying to train up to 10 clinicians, including those that will be trained as PRNs. That says working to hire a Marcus Alert coordinator. They sent me a text on Friday. They did hire a Marcus Alert coordinator. She accepted Friday, so that should aid in speed there. And they're trying to work out their training, what it's going to look like, who's going to train them. And Kelly did say, with the point of pride, she wants me to stress this one. Little to advance notice, they're on track for a July 1 start, which is huge because they have had a really heavy lift there. The last slide, just some other things that we're doing in this region. PD1, they only have to implement Protocol 1. They met in December with their partners trying to see what Protocol 1 is going to look like. So they're moving that way. Here again, we don't have to rush, but at least they're thinking ahead. Mount Rogers has met with 3 of the 6 PSAPs on Protocol 1, and we're meeting with the other 3 tomorrow to get them started heading that direction. And then Friday, we're meeting with Cumberland Mountain. They've got one jurisdiction that has to meet full protocol. That's Tazewell County. The remainder just have to do Protocol 1, but even though they're not even on the clock, they called the other day and said, can we start looking at this? So we're busy out here, and we're doing a lot of, well, I'm doing a lot of running up and down the road, but I love it, and meeting with partners and getting new programs started. So that's what we got going on.
I appreciate it. Thanks, Tony. That was a really good information. And I will pass it off to Hannah to talk about what is going on in Region 4.
Thanks, Emily. I love this meeting because even though I work with these folks, the regional coordinators, I don't get to hear all these incredible updates too often. So I'm just so impressed with all that is going on in Virginia, and yeah, just appreciate the venue to share some updates on Region 4. So I'll be super brief. I know we're at 1:50 and we still have myself and Claudia to share out. Thank you, Emily. This is a timeline that shows the implementation schedule for Region 4. And so as you see on the screen here, there's a map of Virginia because I also need maps to orient myself like Erica. And so Region 4 is that darker blue region in central Virginia. And initially in 2021, the first locality to implement was the city of Richmond, followed by Chesterfield in 2023, then Henrico in 2024. Most recently, Hanover implemented in 2025, and they're underway now. And now we have Goochland-Powhatan, who is finalizing their planning process now, and they are planning to implement July 1st, 2026. And then come 2027, the region of Greater Reach CSB will be implementing. And then finally, in 2028, we will have Crossroads CSB region. Go ahead to the next slide. All right, and I'm just going to briefly cover a few locality updates across Region 4 that have occurred over the past 6 months, so since our last biannual stakeholder meeting. And I'll start with the locality of Richmond, City of Richmond. So in the past 6 months, Richmond has restructured their non-law enforcement response so that their team of a clinician and peer recovery specialist now can be called directly to a scene by a law enforcement officer, in addition to conducting their follow-up and outreach that they do in the community. And they're continuing to really think strategically about how this team can be most impactful, and planning for some additional expansion in the future. So looking forward to that. And then for Chesterfield, over the past 6 months, they expanded their co-response by adding another officer that's solely dedicated to what they call their core team. So they now have 4 officers that operate on their core team. Next for Henrico. Henrico, over the past 6 months, conducted a 2-day interdisciplinary crisis response training, which brought together members of their co-response teams, their mobile response teams, and CIT officers and clinicians. Really incredible in-person training across these disciplines that I was just really impressed by. And then Hanover, finally, they implemented, with their Marks Alert implementation, they implemented a new process so that their on-call emergency services clinician at the CSB is alerted to any mental health call that comes into 911, and then the CSB conducts outreach as appropriate after receiving that alert. All right, and I'll also briefly cover a few key regional data points that fall across the 3 Marcus Alert protocols. To mirror the cadence of this meeting, I'm trying to stick with just the last 6 months. So starting with Protocol 1, which has to do with 911 triage and diversion. Over the past 6 months, 147 low-level Marcus Alert 911 calls across the 4 implemented 911 centers were transferred to 988, and thus diverted from unnecessary law enforcement response. And as Bree mentioned during her presentation earlier, while this may seem low, there are a few things to keep in mind. Many individuals who call 911 are expecting a first responder, and many calls that come into 911, mental health calls come in from third-party callers, which means that they might not be interested in or appropriate for a transfer to 988. But there is still room for growth there, which is why I know folks in our region are really excited for that 911, 988 interoperability training that's in development by the state. And then another data point to share is that over the past 6 months, there's been about 120,000 calls made to 988 from Region 4, which represents 42% of the statewide 988 call volume, which is very large. I'll go on to the next slide here to cover Protocol 2 updates, data updates. So Protocol 2 establishes that mobile crisis response will respond to level 2 calls, but law enforcement will provide backup assistance if needed if the call escalates. So in our region, Region 4, CREST and REACH are the public providers of mobile crisis response, REACH specifically serving individuals with intellectual or developmental disabilities. Ariel mentioned collaboration with CREST and REACH earlier. And over the past 6 months, CREST carried out 307 mobile crisis responses, 17 of which, or just 6%, either required law enforcement backup or law enforcement was already on the scene. And then REACH carried out 428 mobile crisis responses, 80 of which, or 19%, required law enforcement backup or law enforcement was already on the scene. And just to note, that percentage is higher for REACH because most of their mobile crisis responses are conducted in hospital settings where law enforcement is often mandated to be present. And then finally, you can move to the next slide, Emily, for Protocol 3 data points. Protocol 3 has to do with specialized law enforcement response. So I'll just cover 2 key data points for co-response. So in total across Richmond, Chesterfield, and Henrico co-response teams, there were 791 responses conducted in the past 6 months. And an average of all of these responses, 80% of these interactions were diverted from involuntary hospitalization and arrest, meaning that instead, these interactions were fully resolved in the community or with a voluntary connection to treatment. All right, and last but not least, I just wanted to plug while I had the venue here to do so. This Wednesday, myself and the other regional Marcus Alert coordinators will be hosting a Zoom meetup for frontline staff who are involved with co-response or community response across Virginia. So any clinicians, law enforcement officers, firefighters, EMTs, paramedics, and peer recovery specialists involved in co-response or community response are welcome to join and meet folks from other teams across the state. It's really just an informal space to create those connections. This Wednesday at 3 p.m. And if you'd like to register, please just email me and I can help you get registered.
Yeah.
Thank you, Emily.
Yeah, thank you. I appreciate it. That was awesome. And then, yes, just for time's sake, I'll go ahead and pass it off for Claudia to give updates for Region 5.
Hi, everyone, again, and I am going to be brief. I want to thank both Casey and Connie for already shining a pretty expansive spotlight on Region 5, which allows me to be brief today. So I just want to paint a little picture of the teams that we do have implemented, the localities that we do have implemented in Region 5. So Virginia Beach has a co-response team that is an ES certified pre-admission screening clinician that responds with a law enforcement officer. They ride together and are dispatched from the PSAP, as Casey spoke about. Mobile Crisis is really, really recruiting right now. They've been down. But the great thing about Virginia Beach is that they do cross utilization. So the child and youth clinicians, the emergency services clinicians, they all fill in the void wherever is needed so that we can meet the needs of those who are calling. They are peer support is scheduled from 9 a.m. to 5:30 p.m. Child and youth is now fully staffed. And that is the first time that I can say that since I've been here. So we're excited about that. And that's what allows them to partner with the adult MCR to increase their utilization. They operate from 9:30 a.m. to 10:30 p.m. and weekend hours from 12:30 p.m. to 10:30 p.m. July through December updates, they had 188 total calls for service for MCRT. 2% resulted in arrests, which is 5 total. 20% ECOs, 38 total. 0 TDOs, and 77% were deferred from arrest and ECO, which is what we want to see. Most are diverted and use the resources in the community rather than the legal services. Next slide. And Hampton Newport News, Connie told you a lot about this team. They have several care teams. There's a behavioral health clinician and an EMS worker with the Newport News Fire Department community care team. They have 2 teams. One operates Monday through Friday from 7 a.m. to 7 p.m. and Care 2 operates from 9 a.m. to 7 p.m. The Hampton Care Team is a partnership with Hampton Fire and Rescue. They operate Monday through Friday from 10 a.m. to 6 p.m. The CSB Marcus Alert clinicians that can co-respond with first responders in the community has expanded coverage starting in December. They are now operating 24 hours a day, 10 days out of the month. They typically operate 8 to 16 hours a day. The rest of the days of the month, previously we had not achieved more than 22 hours. So it's exciting that they now have periods where there is 24-hour a day coverage. And the team acts as a backup to the care teams during care hours of operation as a primary outside. Okay, that's okay. Keep going. And then Western Tire Order, they are our newest. Their clinician is paired with the Suffolk Fire and Rescue, utilizing the community paramedicine model. They manage operations. Mark 1 are with 1 firefighter, paramedic, and 1 QMHP. That's their modality. The team size increased to 10 fire and rescue personnel, 1 full-time and 9 fill-in, and 2 QMHPs, 1 full-time and 1 as needed. Year 25 stats, 382 calls for service, 524 total encounters, 387, I don't know what those initials are, I'm sorry, guys. And 77 referrals received and processed from operations, 137 Marcus Alert calls, 60 transports to the Crisis Retention Center, and 199 unique citizens served across both programs. So it's a new program, but they are getting better every day. And to drive up community engagement, they have attended events, the Peanut Fest, National Night Out, Suffolk Parks and Recs Children's Neighborhood Pop-Up events, and the Commonwealth Attorneys Back to School Senior event. And I want to highlight that this is a really big planning year for Region 5. We have 5 CSBs of varying landscapes from remote to urban. So I'm sure that come August, we'll have some exciting things to share because they've all been planning and doing well. And that would be Norfolk, Portsmouth, Chesapeake, Middle Peninsula, and Colonial. And that's all I have.
Great. Thank you. And thanks everyone. I appreciate I really thought in putting together this meeting, we weren't going to have much to talk about, but I feel that we have shown otherwise. So I will go ahead and start looking at the chat. I hope I can get to everyone's meeting. If anyone needs to step off, feel free. I will post this on the DBHGS YouTube page, so you can come back to some of these to review for your question. We have started collecting data for IDDD and crisis. Those are for the co-response. We don't look at how many calls come into like 911 or PSAPs, but we do collect those on the co-response unit. I'm not able to say who will be delivering the in-person training content on the blended model, but we probably, actually, I don't think it will be a probably, we will be asking for communities to assist. Which communities, we don't know yet. I think ideally it would be because of the content and the skill building component of it, similar to CIT, where we would have those who are of the differing professions be the teachers of the class. But again, we will have more information for you guys as we get closer. I don't know if that software question was for me or if that was for maybe another presentation. We're not switching to any software. But if it was for me, if you could just specify, I guess. I don't know if you're still on the call.
Emily, I think that software question was for Ashley Hoffman, the paramedic who had mentioned that, and she answered it as well.
Perfect. Great. Okay. I think we have answered all of those in the chat, so I'll let anyone who feels free to ask a question. Now can be your time. Okay, well, here's the Marcus Miller email address as well. So if anyone has any questions, you can send it there, and myself or someone else on the Marcus Alert team will get back to you. Again, I really appreciate, and I'll actually stop recording if I can. There we go. Yes. I really appreciate